Bacterial infections of the skin. Pyoderma. Purulent bacterial infection of the skin. Pyo, pus, purulent. Classification on involvement of hair follicle. Present follicular pyoderma caused by Staphylococcus aureus, known as folliculitis, furuncle, boil, carbuncle. Absent non-follicular pyoderma, localized spreading, localized impetigo, superficial, ecthyma, deep, impetigo bullous or non-bullous, spreading pyoderma, erypsella, superficial, cellulitis, deep. Follicular pyoderma types. Folliculitis, infection of the hair follicle, folliculocentric pustule. Folliculitis, topical antibacterials, like they give clindamycin and stuff like that. I have made videos, short videos on exactly how to prescribe topical antibacterials for folliculitis. It is one of the most common presenting skin problem. Types: furuncle, boil, infection of hair follicle, plus for perifollicle area is involved, that's furuncle. Red in unindurated tender nodule, pus point, topical antibacterials. Carbuncle, infection of multiple hair follicles plus contagious adjacent area, contiguous. Red indurated tender nodule, multiple pustules on the surface, carbuncle. Most common site is nape of neck. Association uncontrolled diabetes mellitus. Treatment: insulin for diabetes, systemic antibiotic, parenteral. And surgical treatment: incision and drainage, surgical debridement of the affected area. Just not long ago a person came with this same problem, and let's see how it was treated. I have made a separate video about that. So here is my short, and listen to this case, which is sounding very similar to carbuncle.
His father with the issues of
Picture a 15-year-old boy coming in with his father with the issues of scabs and sores on the neck, armpit and back of head. On the neck started 1 month ago, in the armpit started bilaterally couple of days ago. No such lesions in thighs and groins. On examination, you can see scabs with honey-colored crust on the neck, and in the armpit you see sores which are tender to touch on bilateral armpits. On the back of the head you see presence of scabs. You take a swab and send for testing to detect the type of bacteria. You make a diagnosis of bacterial skin infection, impetigo. You prescribe antibiotics 3 times a day for 7 days. Aeration, hygiene. You prescribe a topical skin antibiotic fusidin and to wash all clothing. Picture. So this is how it was treated. That guy who presented with a similar presentation of carbuncle, pyoderma. And in systemic antibiotic we chose cephalexin, and for topical antibiotic we chose fusidin. Non-follicular pyoderma. So impetigo, golden honey colored brown crusts. So we also made a diagnosis of impetigo in that care because follicles were not involved. So it was not exactly a carbuncle, but it was more of a impetigo type of picture. But the treatment almost remains same. So definition of impetigo: bacterial infection of the skin, honey golden color, brown crusts. Types: non-bullous impetigo, impetigo contagiosa. Etiology: group A Streptococcus, Staphylococcus aureus. Clinical features: age group children, non-bullous impetigo is in the picture. Lesion golden brown holly colored crust, signs perinasal perioral areas. Complication: remote post streptococcal glomerulonephritis, severe. Bullous impetigo, etiology Staph aureus. Pathogenesis: Staph aureus produces epidermolytic toxin. Lysis of epidermis. Bulla formation. Lesions: flaccid bulla with varnish crust. Side trunk hypopyon sign, collection of pus in the lower half of the bulla, that is hypopyon sign. Note: topical antibiotics used in dermatology: fusidic acid, like we gave to that patient, mupirocin, ozenoxacin, activity against MRSA. Ecthyma, deeper ulcerative variant of impetigo. Etiology: group A streptococcus, most common in lower extremities. Lesion: chocolate brown thick adherent crust, purulent irregular ulcer. Ecthyma, chocolate brown thick adherent crust. Erypsella. So I have made a video on how to differentiate between erypsella and cellulitis. You can check that out. So erypsella is upper half of the dermis plus lymphatics. Group A streptococci, most common lower legs. Lesion: erythematous indurated tender plaque. Margins well defined and raised margins. So cellulitis has no well defined margins, but erypsella has well defined raised margins. Well defined erythematous indurated plaque. Cellulitis: lower half of the dermis plus subcutaneous tissue. Etiology: group A streptococci, Staphylococcus aureus, most common lower extremities, legs. Erythematous indulated tender plaque. Margins ill defined, diffuse margin. Treatment of spreading infection: cefalozine, IV neficillin. So I have only seen cefalozine being given. Staphylococcal scalded skin syndrome. Definition: acute skin exfoliation caused by toxin producing strains of S. aureus. Pathogenesis: focus of infection, conjunctivitis, otitis media. F. aureus produce epidermolytic exotoxin, hemogeneous spread of infection. Richest target: skin. Target protein: desmosomes. Target antigen: desmoglein 1. Acantholysis: rupture of desmosomes. Note: desmoglein 1 is mainly expressed in the upper epidermis, just below stratum corneum. Clinical features: history of focus of infections, conjunctivitis or otitis media. Constitutional symptoms: fever. Skin features: periorificial erythema, crusting. Skin tenderness, sheet-like epidermal peeling. True Nikolsky sign. So we will see a demonstration of this. It's an interesting sign.
A blister here. Okay, so you see a blister here. This is a shallow blister of pemphigus. And if you push on it, well, so we're seeing a negative Asbo-Hansen sign because the blister is not extending. But if you push on it, you see this is Nikolsky sign. And basically it's a pop blister. And I mean the whole point is the skin wouldn't move here if there's no blister because it's nice and attached. But once you have detachment, either in toxic epidermal necrolysis or in pemphigus vulgaris, you see that the skin moves, and that's the Nikolsky sign that I've just demonstrated.
So here There will be true Nikolsky sign, so you will be able to move the blister. Oral lesions are absent. Low concentration of desmoglein 1 in oral mucosa. If you know chickenpox, there could be oral lesions, especially in adults. Differential diagnosis of sheet-like epidermal peeling. Staphylococcus, scalded skin syndrome, normal mucosa, toxic epidermal necrosis, hemorrhagic crust in mucosa. So that is how you differentiate. If it is 10 or if it is S triple S. So in 10, there is lesions on the mucosa, hemorrhagic lesions. Treatment: penicillinase resistant penicillins, IV oxacillin, IV neficillin. Alternate antibiotics: cefazolin, vancomycin, what we use in cellulitis. So first treatment is penicillinase resistance penicillin, IV oxacillin, and IV neficillin. Alternate antibiotics: cefazolin or vancomycin. Acute paranoia. Acute paronychia, nail fold infection, etiology Staph aureus, predisposing factor thumb sucking, clinical features nail fold, erythema, edema, tenderness, pus collection, erythema, pus collection, acute paronychia. Treatment based on presence of abscess formation. Absent antimicrobial cephalexin, dicloxacillin. Present surgical drainage and antibiotics. Borderiomycosis. Definition: chronic suppurative granulomatous disease in response to a bacterial pathogen. Misnomer: not a fungal infection. Etiology: Staphylococcus aureus, others Proteus, E. coli, Klebsiella. Lesions, nodules plus ulcer. Erypsiloid. Etiology: Erypsipilothrix ruseopathiae. Here is an erypsiloid. Risk factor: meat, fish handler. Lesion: purplish erythema, painful edema. Treatment: penicillin. Cutaneous Corynebacterial infections. Erythrasma. Etiology: Corynebacterium minutissimum. Erythrasma. Erythrasma. Etiology: Corynebacterium minutissimum. Lesions: asymptomatic reddish brown hyperpigmentation. Sites: axilla, groin, toe web spaces. Woodlamp's examination: coral red fluorescence due to corpoporphyrin 3 production. Trichomycosis axillaris. Etiology: Corynebacterium tenuis. Misnomer: not a fungal infection. Clinical feature: yellow deposition, concretions over axillary hair shaft. Sites: axilla. So we'll see that this picture is not very clear. Trichomycosis axillaris. Trichomycosis axillaris. So it says mycosis, but it is actually a bacterial infection, and the bacteria is Corynebacterium tenuis. And what is the treatment? Topical clindamycin and shaving of hair. Simple as that. Topical clindamycin and shaving of hair. This is a common presentation: pitted keratolysis. Etiology: Micrococcus, Cryptococcus sedentarius. Pathogenesis: increased sweating, increased bacterium, increased enzyme production that lyse keratins. Pits. Clinical features: pits and depressions. Sites: palms and soles. Treatment: Whitfield's ointment. Keratolytic, right? 3% salicylic acid plus 6% benzoic acid. Whitfield ointment. Pseudomonal infections. Ecthyma gangrenosum. Clinical scenario: Pseudomonas septicemia. Pathology: hemorrhagic necrosis of skin. Lesions: necrotic crusted ulcers. Ecthyma gangrenosum. Hot tub folliculitis. Clinical history: bath in ill-maintained spa. Sites: bathing trunk area. Green nail syndrome due to pyocyanin pigment production. This is a green nail syndrome. Cutaneous anthrax. Etiology: Bacillus anthracis. Clinical history: contact with animal or animal products. Lesion: malignant pustule. Starts as a papule, black eschar surrounded by a rim of vessels. So black eschar surrounded by a rim of vessels. Malignant pustule, rim of vesicles, black eschar. Meningococcemia. Etiology: Neisseria meningitis. Clinical history: fever plus CNS symptoms, neck rigidity. Lesions: petechial rash, non-blanching when pressed with glass slide. Angular cutaneous infarcts. Petechial rash, rashes in meningococcemia. Let's see that. So they don't blanch, they are non-blanching rashes. And there is also angular infarcts. Scrub typhus. Definition: acute febrile mite-borne infectious disease. Etiology: Orientia sutsukamushi. Scrub typhus. Etiology: Orientia sutsukamushi. Black eschar. Vector: trombiculid mite. Infective form: chiggers. Clinical features: fever and malaise. CNS symptoms: lesion eschar, black scab surrounded by erythema. Differential diagnosis for eschar: cutaneous anthrax. History of contact with animal or animal products. Brown recluse spider bite. Treatment is doxycycline. Scrub typhus. Acute febrile mite-borne infectious disease. Etiology: Orientia sutsugamushi. Vector: trombiculid mite. Infective form: chiggers. Clinical features: fever plus malaise. CNS symptoms: lesion eschar, black scab surrounded by erythema. Differential diagnosis for eschar is cutaneous anthrax. History of contact with animal products. Brown recluse spider bite. So if you see an eschar, which is very typical, I'll show you. I have seen one or two. So it is black. So you have to start thinking about these three conditions: scrub typhus, cutaneous anthrax, spider bite. And for anthrax, the treatment is, they didn't write the treatment, but let's see what Antibiotics taken for 7 to 10 days. First line is ciprofloxacin, levofloxacin, moxifloxacin. So that is the treatment. Scrub typhus, doxycycline. Antibiotics taken for 7 to 10 days. First line is ciprofloxacin, levofloxacin, moxifloxacin. So that is the treatment. Scrub typhus, doxycycline.